So I don't remember who, but someone when I first got my cancer diagnosis said that breast cancer is a lot like a choose your own ending, choose your own adventure story. Um, and especially as I approach my breast cancer surgery, I really have been reflecting back on that idea and thinking that it is just a perfectly accurate description of what your breast cancer journey might be. So, um, today when I'm filming is Friday, October 20th. On Tuesday, October 24th, I will have my breast cancer surgery. And hopefully this video will be up on the Thursday following, which will mean everything will have gone well. Anyways, for those of you who may not know me, my name is Sarah. Normally I post, as you might guess from my background, knitting, yarn, spinning related content here on YouTube. But in March of this year, on March 15th specifically, I had the mammogram ultrasound that would change my life and ultimately reveal that I did in fact have breast cancer. I've done other videos on my channel detailing my diagnosis story, my journey to chemotherapy, my experience with chemotherapy, my hair loss journey. Those are all linked in a playlist below. I'll see if I can get it up here as well. And today what I want to talk about is my journey to breast cancer surgery. So of course, not all breast cancer types are the same, and therefore not all breast cancer journeys or stories are the same. For context, I have on my right breast stage 2B estrogen and progesterone receptor negative, HER2 positive breast cancer. Now, breast cancer is considered to be a surgical cancer. That's because it's typically a solid mass tumor, which is going to be, relative to other cancers, easy to surgically remove. And so when my biopsy results came back to my family doctor confirming my breast cancer diagnosis, I was referred to a cancer surgeon first. We met with the cancer surgeon, and this is where the first of my choose your own adventure options and choices was presented to us. Because had my cancer been a stage 0 or a stage 1, something smaller, or perhaps had I been much older than I am, I'm only 35, we would have done surgery first, and depending on the findings of that surgery, then made choices about chemotherapy or radiation. But since my cancer was stage 2B, additionally, it was quite large. We kind of describe my cancer as being a approximately 10 centimeter cookie of a lower grade cancer, a non-invasive ductal carcinoma, with some chocolate chips inside of it of invasive carcinoma. So because that total area was larger, because my staging was 2B, and because I was on the definitely younger side for breast cancer diagnosis, it was presented that the best choice for me might be to do what's called neoadjuvant chemotherapy, which is to do your chemotherapy first and then your surgery second. The way that the benefit was kind of explained to me is that it's a canary in a coal mine situation. While you still have the tumor to monitor, you do your chemotherapy. If the tumor responds, then you know that hopefully any cancer cells that may have migrated outside of your breast are also responding. If you've done your surgery first and you don't have a radiographically evident tumor to monitor, then you can't really determine the effectiveness of that chemotherapy. You're sort of blindly applying chemotherapy, but you don't have that canary in the coal mine of the physical tumor to monitor. And so we did my 6 rounds of neoadjuvant, so before my surgery chemotherapy. Like I said, I've got a video linked up below kind of going over what that process was like for me. It was not fun. So I did my chemotherapy rounds, and shortly before the end of chemotherapy, I did my last round on August 12th. So I believe the end of July, I went back and saw my breast cancer surgeon to talk about the next step, the plan. And the goal is sometime about 6 weeks after you complete chemotherapy to have your surgery, giving yourself enough time to recover from the effects of chemotherapy before going through the next physical hurdle of breast cancer surgery. Now, in Alberta, in Canada, where I live, breast cancer patients are fully covered for as much or as little reconstruction after surgery as they would like. And so you really do have a lot of options on the table. In addition, there are different options as to how much surgery you would like to have. So, like I said, had my tumor been smaller, then a lumpectomy would have been an option for me. And I suppose if I was willing to sort of bear the risks, I could still go down that route. Um, Although I did my chemotherapy and we did see really good response in sort of that larger cookie area of less invasive cancer, that sort of resolved almost to normal. The solid mass tumor in the center did shrink somewhat. So I could, if I wanted to take on the risk that we might be leaving cancer behind, choose the lumpectomy to just remove that center mass tumor from my breast. But I'm 35, I have kids, I'm not willing to bear that burden of risk of cancer resurgence. So for me, it was very clear from the get-go that I would likely be doing a full mastectomy of my right breast. The next question is whether I would go double mastectomy or not. And so I don't have any family history of breast cancer. Additionally, we went ahead and did a extensive genetic testing where they screened for something like 40 plus different known breast cancer genes. And in addition to that, I actually had my full genome sequenced years ago, dealing with a health issue with our kids. And so I know I don't carry any genetic risk for breast cancer, any known genetic risk. I mean, research is always evolving and they're always finding new genes, but for what we know in 2023, I don't carry any known genetic risk for breast cancer. And so my chances of having breast cancer on my left side would be the same as having cancer completely de novo, like completely from scratch. And so there's not really any risk that the cancer from my right side would travel to my left side, because in order for the cancer to sort of travel outside of your breast, it would have to mutate and change. And then it's more likely that you would have metastases somewhere else in your body, which would be a whole different ball game as far as the severity of your cancer. Kind of not worried about preserving breast tissue at that point. So I chose to go with the single mastectomy on the right side for now, because it's less surgery, and I didn't see a reason to give up healthy tissue if I didn't have to. So for me, I knew I would be doing a full mastectomy on the right side. And then the subsequent question, again, choose your own adventure. What amount of risk and what path are you willing to go down, would be whether or not I wanted reconstruction. Again, I'm only 35, and it's one of these things where as a woman we put the most bizarre forms of guilt on ourselves, but I felt really guilty and small that I wasn't brave enough or confident enough to be okay with going flat-chested on the right side. And that's crazy, but I'm a mom, I have young kids. The recovery would be longer if I do some form of reconstruction, so I felt some guilt about choosing cosmetically having two breasts over a quicker recovery so I could get back to being a mom. I know it's completely ridiculous. I have a lot of life ahead of me to live, that I need to be comfortable with my body and comfortable with this massive choice about my body. But I'd be lying if I said that I felt, or that I currently, I'm emotional talking about it, that I currently don't feel like this twinge of guilt or smallness that I wasn't brave enough to just have one breast. Bizarre, I know, but being honest and sharing my feelings and my story, it's one of these things that we tend to do to ourselves as women and as mothers, right? So I knew I wanted reconstruction. And kind of offhandedly, when I found out I was diagnosed with breast cancer, my family doctor, who is a female, said, well, the lemonade from these lemons is that you get a tummy tuck. Because the common way that you see women, when I obsessively went through YouTube and social media to look through breast cancer stories, you see a lot of women who will do the reconstruction where they use your own tummy tissue to reconstruct one or both breasts after your mastectomy. And so going into meeting with my surgeon and subsequently with my plastic surgeon, I had assumed that that was sort of the gold standard. That would be what I wanted. Um, you know, that's sort of what I had assumed going into it. But as I went through chemotherapy and felt the toll of the chemotherapy on my body, um, I became less confident that the reconstruction that I would want would be using my own tummy tissue. The reasoning behind my hesitancy to move forward with that plan are that it is a massively larger surgery. They're called DIEP, like DIEP flap or tram flap. It depends, the names depend on which blood vessels they use. When they transplant, essentially your fatty abdominal tissue up to your breast. And so, where was I going? Lost my train of thought here. So, my hesitancy with those procedures is that the recovery is even larger than a reconstruction that would use like a silicone implant. And again, I have small children, and the thought of especially having been out of commission as a mom in some form for most of the summer, and then to have to put my kids through what would be up to a 3-month recovery of no lifting, of I mean, it's a large incision across your abdomen. And the way that the surgeons describe the recovery is that there's a period where you can't even stand straight up because you need to be protecting that incision and sort of hunched forward. It, from what I had been through, I didn't know that I wanted to put myself through that extensive of a surgery right now. In addition, I'm not an optimist about my cancer. I mean, I know my stats and I know that I am likely to have very good outcomes, but I've got this pessimistic view going into my surgery that they're going to remove it and decide that there is a need for additional radiation, which up until now, I haven't had any radiation. But if they do the surgery and they find more cancer than expected, or cancer in my lymph nodes, which from ultrasound, radiographically, they don't see any sign of cancer in my lymph nodes, but just because they don't see it on ultrasound doesn't mean they won't find it in surgery. So I've got this pessimism of I'm going to come out of surgery potentially needing radiation, potentially needing more chemotherapy. So neither of those things are scenarios that I would want to go through if I'm also recovering from a major abdominal surgery in addition to the mastectomy surgery. Additionally, questions of whether or not that abdominal surgery, that transplant would survive chemotherapy or radiation. So both of those things can kind of put at risk the transplanted tissue. So that pessimism, it weighs on me, and again leads me to feel like it's probably not right now the best time to go ahead with that. So furthermore, talking with the plastic surgeon about the option to do the tummy tuck breast reconstruction, the discussion was that it's a much more extensive surgery, so it requires almost double the OR hours, as well as a surgical team that might be up to twice as large as the one for the implant-based reconstruction. I think he talked about needing 1 to 2 other plastic surgeons being involved. And so logistically, he felt, and we agreed, that just the amount of time that scheduling that, I mean, the likelihood that that would be scheduled within that sort of 6-week window that we wanted to get surgery, and I'm already slightly outside of that. So even just getting the surgery I chose scheduled pushed us to the end of October, when we were hoping for a surgery time sometime late September, early October. Had I gone with the reconstruction using my tummy tissue, that would have likely pushed us into December, if not the new year. And all that time, I still have breast cancer inside of my body. And although I am doing my maintenance chemotherapy, I'm taking my Herceptin and Perjeta every 3 weeks for almost a year, that's may or may not be sufficient to combat leaving known breast cancer tissue inside of your body. Anytime during that time, cells could mutate and lose their susceptibility to targets to that HER2 receptor. So, from a logistics standpoint, from a risks standpoint, and from it being, in my life, whether or not it's the right time. Ultimately, I ended up choosing to go with a implant-based reconstruction. So my surgery is officially a right-sided single mastectomy, skin saving, nipple sparing, hopefully, and we'll talk about that, with a silicone implant or tissue expander, and we'll talk about that, and with sentinel node removal, if not more lymph nodes. So 3 more things to talk about here. It's, like I said, a choose your own adventure, and also I'm a little uncomfortable with the fact that going into surgery, there are a list of unknowns of what I might wake up with. So because my breast cancer is contained in the breast tissue and I don't have any lesions that extend to the skin, so it will be skin saving. And the hope is that it will be nipple sparing. My cancer is on the top half of my breast and somewhat close to my nipple. And so what the surgeon said the procedure would be is that in surgery, they will take a sample of the tissue sort of just under your nipple and send that quickly off to pathology to test whether that sample tissue immediately underneath your nipple is cancer containing or if it is a cancer-free zone. If it's cancer-free, then they will save the nipple. If it's cancer containing, then they will not. Now, if it's cancer-free, that doesn't mean that there's not, that there's 0 chance of recovery. Again, this is one of those, how much risk are you willing to accept? But even the mastectomy itself, there's not 0 chance of recurrence of cancer. So we're gonna go with this. We're gonna test it for the pathology, whether it's likely that the tissue in and around the nipple is clear of cancer cells, and hopefully spare it. But that'll be, a question for the pathologists and the surgeons day of. And then if they aren't able to spare the nipple, then unfortunately the amount of skin that they need to take out in the incision may result in there being too little skin afterwards to put the implant in. So if this happens, then we've also consented that they might put in a tissue expander. So a tissue expander is like an empty implant that they can inflate slowly in order to allow the skin to stretch and grow to accommodate it. So there is a chance that I wake up flat-chested on this side with as much skin as possible saved with the tissue expander in, which would require subsequent appointments to expand the expander, a secondary surgery to swap out the expander for an implant. They're not a permanent scenario. And again, I won't know about that until I wake up from surgery. So sorry if there's some sounds in the background. I've got a full house today. My parents flew in to help out while I'm away for surgery and in the recovery phase after, as well as my kids being home from school because it's PD day. So it's a full, loud, busy house, and I'm sneaking away to get this recorded. So we talked about whether the surgery would be nipple sparing or not, and that there might be the potential that rather than the implant, which could be permanent, that I might wake up and have a tissue expander and require a subsequent second surgery. Less than ideal. Now, the last sort of question mark with this surgery, and I guess it's not me choosing my own adventure, it's my body having chosen for me, is that with breast cancer, and I guess a lot of solid mass tumor types of cancer, you have your local tumor, and then you can have the tumor spreading to the nearby lymph nodes. That would be the next step before the tumor potentially became metastatic throughout your body. Radiographically, so on ultrasound and on my mammogram, they don't see any evidence, although this was, back in September, they didn't see any evidence of any spread to my lymph nodes, but that doesn't mean that there aren't cancerous cells there. And so what they usually like to do is remove what's called the sentinel lymph node. What that means is they will remove the lymph node that is closest or most likely to be the first one that the cancer would travel to. So the day before my surgery on Monday, I'm going to go for sentinel lymph node mapping. This is a procedure where they inject a tracer into your breast near your cancer, and then you wait a couple hours, and then they do some imaging, and they see which lymph node has picked up the most of that tracer. That lymph node would be the sentinel lymph node. And they mark it. I've heard, but I don't know for sure, that they literally just with Sharpie on your skin mark the location of that lymph node. We'll find out if that's the case, but they mark it, and then during surgery, that would be the one that they take out first. Now, again, this is where they're going to make decisions day of. So they'll take out that sentinel lymph node, send it quick off to pathology, where they will determine whether or not the sentinel lymph node has cancer cells in it. If it's negative, then they would stop there. If it's positive, if there are cancer cells in that sentinel lymph node, then they'll take the next couple of lymph nodes upstream, and then the next. So, I mean, the idea is to remove as much of the cancer as they possibly can, and that could be as hopefully easy as just the sentinel lymph node and it's negative, or it could be a number of lymph nodes removed. Obviously, we're hoping for just the first and that it's negative. Again, because the dissecting further into your armpit to get at more lymph nodes means a more aggressive surgery and a longer recovery time, but also the increased likelihood that I would need further treatment, whether that be radiation or chemotherapy, I don't know. So that's sort of all of the up in the airs as far as my surgery. Now, believe it or not, despite this being a surgery that I believe one of the surgeons said could be like a 6-hour in the OR type of deal. So despite what seems like a very extensive surgery, this is going to be a day surgery procedure, where unless there's complications, you aren't even admitted to hospital overnight. So again, hopefully no complications, and that'll be the case. And then we'll stick around in Calgary for at least the first 24 hours before coming home to rural central Alberta. And then recovery should be back to normal, so says the plastic surgeon, by the 6-week mark for sure, as long as no obvious complications. And that I can expect to probably have a fair bit of numbness on my chest that may be permanent, because quite often nerves are removed when they remove the breast tissue. To have some swelling under your arm. I suspect I'm going to have limited range of motion and use of my right arm for a while after surgery. With the removal of lymph nodes comes the risk of lymphedema. Edema is a buildup of fluid in your tissues. Your lymphatic system is critical for the removal of fluid from your tissues. And if they have to remove a significant number of lymph nodes, your risk of lymphedema, which is like excess buildup of fluid in a limb, would go up. So be on the lookout for that, and hopefully we have good outcomes with regards to that. Yeah, so it's not an insignificant surgery. I think that sometimes in the media you see a celebrity with breast cancer and it's like, oh, they had a mastectomy and a reconstruction and off they go. And, you know, there can be lifelong consequences, doesn't feel like the right word, but there can be lifelong effects of this surgery that you don't know about until you're in it. It's not, well, you go for your mastectomy and off you go. So I've got a fair bit of anxiety leading up to surgery. Not, an excessive or an unnatural amount, but I'm certain there will be quite a few tears between myself and my husband mine, not his, in the hotel room the night before surgery. And also a little bit anxious because my past history with surgeries is that opioid pain meds make me so nauseous and aggressively vomiting that they're almost intolerable, or sometimes are intolerable for me to take. So curious as to what the pain level and pain management situation will be for me post-surgery. All that said, this week is going to be a probably write off from me. So that's why I recorded this beforehand to post today on Thursday. Anyways, I think I'm rambling a little bit now. I don't have any more notes about things that I wanted to make sure I discussed in this video. So I will wrap it up here just in saying a big thank you to everyone who's been watching these videos. The feedback that I've had has been really heartwarming. And the feedback that these videos have been helpful to other people going through similar journeys as mine has also just, it's made me feel a certain kind of pride. I don't know. It's been really heartwarming, and I'm glad that I'm putting these videos out there. Even if only just for me, because the process of, you know, I write out sort of little notes on my computer of what I want to talk about stepwise, and then the process of putting my experience to words and then editing into these videos has been an important part of my healing journey. And so thank you. Thank you for your response and for being here and for watching. I appreciate the subscribers that I've been getting from the cancer videos. I'm sorry if you subsequently leave when my channel reverts back to yarny goodness all of the time, a yarn obsession, if you will. But I'm glad that you guys are here. I am so grateful for every comment that you guys leave me below, and I just truly hope that you find something helpful or useful in these videos, because I know that I did in watching other people's. That's all I've got for today. At the risk of being emotional, if you are the type of people who believe in sending healing thoughts, vibes my way, I'm sure I would appreciate them. So, little emotional, little scatterbrain now. That's all for my pre-breast cancer surgery video. Once again, I'm Sarah. This is the Yarn Lab. This is my cancer story. Thank you. Thank you so much for being here.